Now, moving on, my close friend Rishi is coming on clinical of precordium in a cardiology case. Probably his style is different, so please come. Rishi.
Okay, so a very good afternoon, all of you, friends. Thank you, sir, and my teachers for giving me this opportunity to discuss clinical cardiology with you all and the examination of the precordium. Now, you have to face this talk after an interesting talk of interventional cardiologies, which is thrilling and exciting. And it's the siesta time, post-lunch. So my job would be to keep you awake first for the next 50 minutes. And if I can do that, then probably rub in a few points that you can take back home and benefit a little bit in your clinical examination. So for the first thing, I would like to have a little survey of what the audience is like. So how many of you are first year or second year DM, DNB students? Can I have a raise of hands, please? First and second years. And how many of you are exam going final year DM, DNB students? Great. So can we have one from this table? One from this table? Anyone? I would like 5 final year students who would like to interact a little bit more, because it will be difficult to interact with the entire audience. So that would be a sample. So we can have any 5 final year students who can come here. We were just discussing, and so that we don't sleep in between the lecture. It's a long lecture. Anyone? No, it's not a test, it's not an examination. Please come on. Oh, all 5 from this table. Anyone can pick up. It's not going to be a test, it's going to be just a question. So as to allow me to assess what is your knowledge level from which to go high. Great. Great. So I've been given, my time was actually 50 minutes, so if you can reset the clock, that would be less. Yeah. So where are you guys from? Which is your institution, please? Arna, Delhi?
Central Medical College. Central Medical College.
Great. Same. Okay, you can have one more chair. Any ladies, anyone from the ladies final year? Let's have a good cohort. Come on, anyone. It's not going to be a test. Okay. So what I will do is that apart from talking about precordium, I would just briefly go to what should be the construct of your final year long case, because that is the time, if we have, especially the first long case that we are going, generally we get 2 to 3 cases in our examinations. But if the construct on, a lot of people and almost everyone go on to make the same kind of mistakes, and which we see repeatedly over years. So based on my past experiences, I would try to hit those points. And before precordium, I would like to take you through. So today, as part of my main presentation, we'll be talking about inspection and palpation of precordium. Then we'll be going to auscultations, the heart sounds, murmurs, the clicks. And then I would be briefly touching upon dynamic auscultation. So dynamic auscultation is a separate talk. I remember last time I was in Hyderabad for faced the examiners, dynamic auscultation was an individual talk that I took. So I would be speaking on dynamic auscultation, the salient feature in the end. So whenever you are going into the final year of your examination, remember, almost all of you know the diagnosis of your case before you get the case, before you even start to examine the case. And that's really a tragedy, and it's really a trap that I would advise not to fall into. Start with an empty slate. The examiners are not testing you in whether you are able to make the diagnosis or not. They want to know what is the construct of your mind in order to reach that diagnosis. how much academic investigative your mind is in order to reach the diagnosis, so that you can do it predictably over the next many years that you are supposed to practice, and not just make one diagnosis in clinical case. So that's one thing. So at least try to start as clean as possible, and whenever you reach to precordium or history, precordium examination, remember you have already gone through history, differential diagnosis, general examination, and the examination of pulse, JVP and DP. So take the whole picture into construct. Whenever you reach the examination of the precordium, don't forget about what your history was, or what your general examination was, or what differential diagnosis that you were considering, or what were your pulse, BP and JVP findings. So as part of your cardiology case, pulse, BP and JVP should not be a part of your general examination. Your examination should be consisting of general examination. Examination of pulse, BP and JVP should be the middle part, which should be very important, and then you should move on to the precordium. So whenever you reach a precordium examination, try to keep the entire building that you have been constructing, and then do the precordium examination in that background. Do not go on one fancy small finding that you get in your auscultation and try to give too much weight to it, and ignoring all the other directions, all the other things that were pointing in a different direction. So of course, sometimes we are trapped that, okay, we have found this finding that, there's a paradoxical split and nobody else has picked up the split. We get so obsessed by it that we fail to see everything else. Do not fall trap to try to impress your examiners by one single very highlighting feature finding that no one else has picked up, whereas missing the entire picture in between. So you should keep the hard points in clinical examination, give them more value than a soft, fancy finding. These are common mistakes which everyone is doing. And then many a times when you are going in your examinations and there is a difference of opinion, your examiners will say something to you as a joke or as a suggestion. It's a sign that they want to shift the conversation to a different direction, but we are so obsessed with whatever we have learned during the examination of our case, and we are very sure that the diagnosis is right because it has already been told to us by our friends. We fail to pick up those hints, and then things start to go messy. So whenever an examiner is suggesting you something, okay, you can have your firm point of view if you are confident, but try to listen to the hint that has been given to you, and then take the conversation in that direction. So these are the philosophical points general for the case. Coming on to the examination, before I come again to the precordium examination, I would briefly talk about a general examination. And that, whenever you have to describe pulse, general examination, JVP, apex, apical impulse, apical beat, then you can have any, try to remember to say normal things. If you have to describe the normal JVP, try to memorize in your mind how will you say that normal JVP. Because whenever you say a normal JVP, examiners may get offended. You have to say JVP is normal in height and waveform, normal respiratory variation, and the cardiovascular differences, that's it. So similarly for pulse, and similarly if the general examination is normal, no point stretching about what is the BMI, what is the socioeconomic class, lying lateral. Nobody is interested in that. Everybody is interested in coming to the findings. So learn to speak something in both in completeness as well as speed, so that you have said everything that is supposed to be said, but you have not wasted your time too much on nutrition, on height and upper body, lower body and arm span, until and unless it is relevant for the case. For example, if the general examination is normal, you can go away by saying there is no pallor icterus edema cyanosis clubbing, there is no hepatosplenomegaly, abdominal system, respiratory system, musculoskeletal system examination is within normal limits, and you are done. So you can get over this normal general examination in saying one single line: no pallor icterus edema cyanosis clubbing, no hepatosplenomegaly, abdominal system, respiratory system, musculoskeletal system is within normal limit, fundus findings are normal. It's complete, and don't waste time before you quickly move on to the more interesting things. Of course, if there's something abnormal or something relevant to the case in that examination, then of course you will have to give it due recognition and due time. Okay? Right. So, coming to my talk per se, in the next 40 minutes or so, about precordium. So what do you understand? I mean, the first point I wanted to discuss, if someone has a precordial bulge, inspection and palpation are supposed to be spoken together, what do you understand? You say there is a bulge at the apical area.
Cardiac chamber enlargements.
Huh?
Enlargement of cardiac chamber.
How many chamber enlargements, how many LVH, how many RVH, how many left atrial enlargements have you seen that have produced bulge in precordium? Anyone? Please speak in the mic.
Precordial bulge seen in shunt lesions.
Mic.
Or, shunt lesions.
Shunt lesion.
Okay, so always remember that chamber enlargements will not produce precordial bulge until and unless they have present before the fusion of the costal cartilages in the ribs, which happen at the age of 8 to 10 years. So if the chamber enlargement is happening, like might happen in the shunt lesions, if the chamber enlargement is happening before the age of 9 years and 10 years, then there is a chance that the chamber enlargement can produce a precordial bulge. After that, precordial bulge is never produced by chamber enlargement, although they can be produced by aneurysms of the vein artery, by tumors, by other things, but chamber enlargements will not. So if you are getting a cardiology case which is not a tumor or not an aneurysm kind, and you are getting a precordial bulge, it means that the chamber enlargement was present before the age of 9 to 10 years, and that will give you some sense of idea what was the onset of the disease and what has been the course of the disease. So very, very important. Can anyone in the audience tell me what an apex beat is? Define an apex beat. What is the definition of an apex beat? Yes, please.
Lowermost and outermost point of definite cardiac impulse.
Perfect. The first time in my life I have heard someone to describe it. So it's a, and can you describe it in more detail? What are the qualities of apex beat? How is it defined as? Other features that you say?
Producing thrust to the palpitating chamber.
Uh-huh.
Producing thrust to the palpitating chamber.
So whether it is tapping type, hyperdynamic or heaving type,
Area?
how much is the localized area covered, and whether it is confined to a single
Area.
or the
So how do you define diffuse versus localized?
if it is more than one intercostal space, it is
Exactly. So that was the point I wanted to highlight, the gap in the nomenclature I wanted to highlight. Now come back, you said apex beat can be diffuse if it's more than 2.5 centimeters. Okay? Come back to the definition of apex beat. What did you say? Speak loudly to everyone.
lowermost and outermost point of the
Point. How can point have an area? Mathematically, point can never have an area. Always remember, in your description, in your palpatory findings of apex, describe apex beat and apical impulse as different entities. Apex beat is the lowermost and the outermost point of a definite cardiac impulse, and it tells you only and only whether cardiomegaly is present or not. You can go on to extend that if it is lower and outer, then it is probably LV, and if it's only outer RV, but might as well don't say. It is just telling you whether cardiomegaly is present or not. All the other features that are described are a part of description of apical impulse, whether it's forceful or not, sustained or not, diffused or not, and what are the other accompaniments. But apex beat is only and only telling you about cardiomegaly being present or not. Okay? So define apex beat and apical impulse in a little different setting. Many examiners will not notice it, but many will try to catch you on this point. So that is another thing. And then of course you can describe it in the pulmonary area. You can have a palpable pulmonary artery or a palpable PB. Again, a lot of time children get confused here. Palpable P2 is a palpable sound of the pulmonary vascular closure. It is tapping in nature. It is never visible, while pulmonary artery pulsations are more diffuse. They are visible also sometimes. So you can differentiate between palpable P2 and palpable pulmonary artery pulsations, both of which might have different connotations in your clinical examination. And then of course parasternal area. Again an area of confusion, because parasternal area, the right way is to see the elevation or the feeling from the edge of your hand, keeping your elbow straight so that your shoulder is acting as a fulcrum. If you feel the impulse, but if your hand is not raising, it is grade 1 impulse of RV. If it raises your hand, but you can suppress that impulse, it is grade 2. And if it raises your hand and you cannot suppress it, it is grade 3. Sometimes grade 3 impulse, some examiners will say as RV heave, while sometimes some other examination will grade 2 and 3 both as RV heave. But again, you can, to be on the safe side, don't say heave, say grade 1, grade 2 or grade 3 RV pulsations. And another pulsation that you can feel in the parasternal area, in the right parasternal area, is the LA pulsations. To differentiate between LA and RV will come with the apical impulse and LA will come at a gap of apical impulse. And then after relaxing the abdomen, you can look at the epigastrium. The two things you are looking for again is an RV, which you feel at the tip of your finger, and aorta, which you feel at the base of your finger. So all these things are important for inspection and palpation. Again, a normal, very, 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 very important point, because by the time you have completed, I would say, everything that is supposed to be told by this slide, I would say that you should have your diagnosis. By the time you are through with your history, the interpretation of your history, asking provocative questions about differential diagnosis and ruling in or ruling out differential diagnosis, after your general examination, after the examination of your pulse, your JVP, your blood pressure, and your apical area, and all the impulses, you should have your diagnosis. You only confirm your diagnosis by stethoscope and try to find out additional findings, but the predominant core lesion should be there. So that's why this slide is very important, and this is why part of that slide is hidden. So again, how do you define a normal apex? Any one of you. I'm using them as sample because it was difficult to write.
The normal apex is outermost in the outermost lowermost point of the palpation.
Normal apex P3.
And apical impulse is just 1 centimeter internal to mid-clavicle line, or just medial.
No. Apical impulse, you have already told about. The first line I have written in red is for apex beat, because that the location is defined only by apex beat. Now you are coming to apical impulse. What are the 3-4 headings in which apical impulse is described?
So first is the location.
Not location. Location we have already explained to you again and again. Apex beat, the location is
duration.
over.
Duration. Sir.
Duration. What is the normal duration?
Sir, less than half of the systole.
Okay.
Less than 50% of the systole. Then is the area.
Area.
Then is the, sir,
how much is the normal area?
Sir, normal area less than 2.5 centimeters square.
Less than 2.5 centimeters and only occupying 1 intercostal space. If it's more than 2.5 or more than 1 intercostal space, it is diffuse.
Then it is RV type or LV type.
Forceful. Forceful. Is it forceful or not?
Is it sustained or?
RV and LV, I would advise you, not to go too much into detail. Of course, if there is a medial retraction, you can say it is LV. If it is medial, is moving, the entire thing is moving, you can say RV. But generally, apical impulse is described as forceful or not forceful, sustained or not sustained, localized or diffuse, and whether diastolic events are any thrill or any S3 or any S4 are palpable. Okay, systolic or diastolic. Any thrill or any diastolic events are palpable. Fine. So now coming to this combination, this thing which is hidden. So Let's talk about four combinations of force and sustenance. You can have a normal force and not sustained. You can have forceful but sustained. I can't say it. Then you can have forceful but not sustained, forceful, sustained, not forceful, sustained. Now fill in the blanks on the right side of the screen. Who's going to do that? Anyone can do that? What do these four combinations mean? Because this will actually, by the time you finish this, your diagnosis should be with you, at least in rheumatic heart disease. Anyone? Yes, please. The guy in the green shirt, yes. Let's start from the first. Let's follow some order. Normal and normal. Not forceful, not sustained. Give him the mic, please. Not forceful, not sustained. I will make your life easy. The normal, if I can. Normal. Okay? Come to forceful, but not sustained.
Forceful and sustained is the LV.
No. That you are telling me, but I am asking you, what is the second line? Forceful, but not sustained.
It's a hyperdynamics. Hyperdynamics.
Okay?
Forceful and sustained is the hypertrophic, concentric, heaving type. Heaving type, sir.
What does it show? What lesions will it signify?
Concentric LVH. LVH, concentric aortic.
Pressure.
LV outflow obstructions. LV outflow obstructions, of course, pressure overload. And then, what is not forceful but sustained?
Heaving. Inflow obstruction.
Inflow obstruction. That's the game. That's the catch. Any one person stand up because yes please. Great. LV dysfunction, that's great. That's great. So the point is that whenever you tend to memorize it, you will forget again. Now you have to go, why do we feel an apical impulse? Why do you feel an apical impulse? In which phase of cardiac cycle do you feel apical impulse?
So in the isovolumetric systolic phase, we feel the
Isovolumetric?
isovolumetric systolic contraction.
The isovolumetric contraction. So what happens? Your both mitral and aortic valve are closed. The ventricle starts to contract. There occurs the apical impulse. Now there's the ventricle has blood, but it is contracting, but it can't throw the blood out. So it will go to a torsion force and you will feel the apical impulse. As soon as the aortic valve opens, all the blood will gush out into the aorta and the ventricle will go away from the chest wall. That is why it is only felt in the first 1/3 of systole. Up to half is normal. Beyond half, you say it is sustained, but it is generally felt in the first 1/3 of systole. So, anything which prolongs the opening of the aortic valve, for example, LV outflow obstructions, will cause a sustained apex. At the same point of time, if LV takes longer time to generate pressure to overcome the aortic pressure, if LV takes a longer time to generate sufficient pressure to overcome the aortic pressure so as to open the aortic valve, again, the apex will come and it will take a longer time to go away. It will be sustained. But it will not be forceful because LV dysfunction. So LV dysfunction will give rise to a not forceful but sustained apex. Now you have imagined you have seen your pulse, you know your JVP, you have a hyperdynamic pulse, you have white pulse pressure, you have Corrigan signs positive, and then you get an apex which is forceful and sustained. Theoretically, it should have been a non-sustained because of an AR situation. That was you were expecting. But now you get a sustained apex. The interpretation can be only two. You have a significant aortic stenosis attached to it, or the AR is now going into LV dysfunction. Correct? and the location of the apex will also guide you whether apical beat will also guide you if the cardiospaghetti is present or not. So that's why I'm saying that if you have your pulse, your BP, your history, and your precordium examination by palpation, and you have seen your apex beat and apical impulse, your diagnosis should be with you with a reasonable level of certainty. Are we clear up to now? Do I have your attention? Yeah? Okay. So here is it. Not forceful, not sustained is a normal apical impulse. Forceful but not sustained is a hyperdynamic condition, any hyperdynamic condition, the prototype being AR. Forceful and sustained is generally LV outflow obstructions, and not forceful but sustained would be LV systolic dysfunction. Okay. So if I had your attention to here, let's move on to now you have your diagnosis and you want to kind of pick up the stethoscope and do some fancy work and try to confirm your diagnosis. We will discuss about the hard sounds, we will discuss about clicks, we will briefly touch upon the movements. So, whenever we talk about S1 and S2, in generally speaking, no one talks about splitting of S1 and M1 and T1, but splitting of S2 is important. In first hard sound, generally it's the loudness of the first sound that is taken into consideration in the examination, and that loudness is dependent on a lot of factors. That loudness is dependent on the structural integrity of the mitral valve. If the mitral valve structure apparatus integrity is suffered, if there is caudal rupture, if there is heavy calcification, if there is infective endocarditis on the mitral valve, then the S1 will become soft. For the time being, I am focusing S1 for the mitral valve only on M1 because T1 is significant only in certain rare conditions, but let's focus on the closure of the first heart sound to mitral valve. It also depends very, very importantly, and almost always you get cases and combination of mitral stenosis. So it will depend a lot on the position of the mitral valve at the onset of the ventricular systole. In mitral stenosis, there is prolongation of the flow. The mitral valves are wide apart during the onset of ventricular systole. They come back with a force and the mitral valve is thickened, it's fibrosed, it produces a larger sound because it is far away during ventricular systole, and when it comes back to a longer distance, it produces a larger sound. It is also dependent upon the flow across the mitral valve, or flow across the valves. For example, in ASD, there would be a loud T1 consonant because there is a lot of flow across the valve. Again, the valve would be open, a lot, wide open at the onset of the ventricular systole, and it will come back with a longer duration, longer distance, and therefore it will produce a larger sound. And the same thing will happen with shorter PR intervals. Long PR intervals and premature closure of mitral valve, as would occur in acute ARs or sometimes complete ARs or LV dysfunction, will soften the S1. It will also depend upon, there are so many factors with the S1 sound, it will also, and why these so many factors are important. Suppose in a case of mitral stenosis, you are hopeful of hearing a loud S1, but you are not hearing a loud S1. So we will have to think of all these things, that these things might be an additional finding there. There may be an associated AR, there may be heavy calcification, there may be some degree of mitral regurgitation also which is helping us. So all these things you need to construct and bring into the focus and bring into the collaboration. So all these things are important. So another factor that governs the loudness of the mitral valve is the, or the first heart sound, is the integrity of the isovolumetric contraction. If you have an associated VSD, if you have MR, if you have LV aneurysms, then this isovolumetric contraction phase is compromised, and it will produce a softer S1. Of course, it also depends upon myocardial contractility and heart rate because of so many of these combinations of these lesions. Coming on to the nemesis. The nemesis is actually the S2. So S2, unlike M1, is to be this. S2, unlike S1, needs to be described not only on the loudness, and loudness here is to be described, loudness of both the components need to be discussed. It's also very, very importantly, it has to be discussed in terms of the splitting. So, we have to, the first thing, can anyone describe why P2 comes after a gap? Why there's a gap between P2, there's A2 P2 combination, why P2 comes a little later? What's the concept of hangout interval? Anyone? Yes, please. So what do you mean by hangout interval? Right, absolutely right. So these things depend upon the compliance of the vascular structure. Remember that the left and the right side of heart are pushing equal amount of blood. But systemic circulation is distributing in a much larger area, whereas the pulmonary circulation is a very localized circulation handling the same amount of blood. And to handle same amount of blood in a smaller area in terms of in gross area, your blood vessels need to be much, much more elastic. And the S2 of the individual side, A2 and P2, does not happen at the crossover between the pressure of whenever the aortic pressure will overtake the ventricular pressure, the valve should close. But actually, A2 and P2 will happen after a little lag of this crossover time, because you need the point of the hangout interval, and of course there is the valves in a dynamic motion forward. It takes some time to come back and close. So the actual closure of the valve will happen sometime after the pressure crossover between aorta and or the great artery and the ventricle. And the absolute definition of hangout interval, and that's why the compliance is larger, and the absolute definition of hangout interval is the time distance between the pressure of the ventricle and its great artery at the level of intersuda. So the hangout interval of pulmonary circulation is longer. It takes longer for the pulmonary valve to close to produce P2. So A2 will come first and P2 will come second. And that's why there is a gap. So what are the features? The most important feature that governs the loudness of A2 and P2 is the pressure of the great vessel beyond the valve. The aortic pressures almost always would be higher than pulmonary valve. Therefore, A2 will almost always be higher, louder than the P2 component. So in A2 and P2, remember 2-3 things. First, A2 will, of course, we're not talking about pulmonary hypertension severe times, but A2 is generally louder than P2. A2 comes before P2. A2 is louder than P2 even in the pulmonary area. Remember this fact, and it will be helpful to you. A normal P2 is not heard away from the pulmonary area. If you remember these 4 things, how will you define by the loudness of your P2 component or A2 P2 mild, moderate, and severe pulmonary arterial hypertension? That's my question to you. How will you do a clinical examination and say that this pulmonary arterial hypertension is mild, moderate, or severe based upon the auscultatory findings of P2?
The loudness of P2 is more at the well here at the apex, P2 is severe.
Excuse me?
The loudness of P2 is well here at the apex. It can be said as severe pulmonary arterial hypertension.
No. And mild, moderate, severe, how do you? So, we may have one answer, but until and unless you have a continuum of how to describe mild, moderate, and severe, of course there would be other signs of pulmonary artery heave and a TR and a PR, everything else. But based upon P2, how do you say that?
P2 is well here at the apex.
It just means, and what is moderate then? I'm asking you to classify it on mild, moderate, and severe. Anyone? Anyone? Yes, please. or someone, one person.
Sir, if P2 is equal to A2, nearly equal, is equal to A2, it is considered as mild. If it is louder than A2 and there is narrowing of the splitting, it is considered as moderate. And if it is loud and banging and there is no splitting, which is appreciable, it is considered as severe.
Yeah, so there's two ways you can describe it. As I said, even in pulmonary area, A2 is louder than P2. So if A2 becomes equal to P2, it says that it is a loud P2. If it becomes louder than A2, then at least it is a moderate degree of pH, and sometimes very loud with the retrograde masking when it's find it difficult to hear an A2 in the pulmonary area. Of course, splitting we will come to a bit later. Then that is the one way of saying whether it is mild, moderate or severe. Another way of saying is, if you have a loud P2 that is equal to the aortic sound in the pulmonary area, but it is heard only in the pulmonary area, it is mild. If you start to hear your P2 anywhere between apex and your pulmonary area, anyway away from the pulmonary area, it is moderate. If you are hearing a P2 at the apex, it is a severe form of PAH. And therefore, if you hear a splitting of sound at the apex, it automatically means you have severe degree of pulmonary arterial hypertension. Am I correct? So you can take it both by the loudness in the pulmonary area in comparison to A2, or you can see how far away from the pulmonary area you can hear P2, and then you can say that it is loud, it is mild, moderate, or severe hypertension. Now the splitting. So for splitting, we all know that A2 comes first and P2 comes afterwards. For anything to make the splitting longer, you will need either the aortic sound to come before, or you will need pulmonary sound to come later. There can be electrical causes for it, and there can be mechanical causes for it. The pulmonary sound will come later in right bundle branch block. The aortic sound will come early in a left ventricular beat. So in electrical activities, ectopic beat. So LV ectopic or right bundle branch block, both will cause widening of S2. Similarly, if you have increased flow across the pulmonary valve, it will take a longer flow, so your P2 will start to come later. So for example, ASD, pulmonary stenosis, right ventricular failures, your PT will be delayed and you will get a wider gap. And similarly, in mitral regurgitation, you have ejection fraction, you have blood going, so the aortic sound will come early, so you will have again a widening of S2. Am I with you all? Am I with you all still? So similarly, for the splitting to become narrow, you would require either the aortic sound to be delayed or the pulmonary sound to be early. So you can have left bundle branch blocks or the right-sided ventricular beats. Or you can have aortic stenosis and LV dysfunction. The same things you were applying for the right side apply for the left side, AS, LVF, and you can, and similarly TR, for ML was there, TR was this side. So these will come a normal, narrow splitting or a reverse splitting. Now remember, narrow and reverse are a continuum. You have a narrow splitting, then it becomes a single S2, and then it goes away and becomes a reverse splitting. And how do you describe that? How do you describe a normal splitting, a wide and variable splitting, a wide and fixed splitting, single S2, and paradoxical splitting? Anyone? This is a little tough one.
Sir,
Yes.
in normal splitting, sir, on expiration there is only one sound. In inspiration, both A2 and P2 are audible.
If you hear splitting only in inspiration and not in expiration, it is a normally split sound. Great. Normally split.
In wide and variable, both in the expiration and inspiration, A2 and P2 are audible. but the duration is variable, sir, in the inspiration and the expiration. In inspiration, duration increases, sir.
Very good. So you hear splitting in both the cycles of respiration, but in inspiration it is longer and in expiration it is shorter. Great.
In wide and fixed, sir, split is present in both inspiration and expiration, and duration is fixed, sir.
Perfect.
In single only S2 is heard, sir. A2 and
In
P2 are
both
fused.
the phases of respiration you hear only one sound.
Yes, sir.
And what is the reverse of paradoxical splitting?
In paradoxical split, sir, in inspiration only single sound, and in expiration both P2 or P2 and E2 is audible.
Perfect. Perfect. So in expiration you will hear the splitting, but in inspiration you will not hear the splitting. And of course the examples of wide and fixed splitting are ASDs and why does it happen? Wide and fixed splitting? Why does it happen in ASD?
Fixed, sir, because the respiration variation is not able, is not
Yeah,
there, sir.
so the right side, it's already so much volume is flowing in that a little bit of respiratory changes are not appreciated here, and similarly in the right heart failure. And what are the examples of singles thing, apart from the fact that single S2 may be a part of continuing of narrow A2P2 gap, which have become now fused and it has become single, while a single S2 happens also because of many other reasons. You have only one valve, for example truncus. You have one valve which is atretic, for example pulmonary atresia. You have a posterior position of the valve, so you can only hear one sound, for example transposition complexes. And sometimes one heart sound may be so loud that you cannot hear the second heart sound, and that is called as the phenomena of retrograde masking, and that also is one of the causes. So single S2 has got multiple reasons. Many a times when we are not able to appreciate the splitting, we go on to commit that S2 is single. It is much sensible to say that I cannot appreciate splitting rather than saying it is a single S2, because then you will have to come down to one of the other reasons why you are saying. If you are not able to appreciate it, say to your examiners, I am not able to appreciate splitting of S2, but that would be a saving grace. But if you commit that it's a single S2, you will have to give one of the other of the explanations, and then you might be in trouble. Okay? Thank you. Great answer. Coming to the S3, the S3 and S4 are diastolic events. These diastolic events generally are low-pitched events. They are sometimes better felt than heard. And from a point of view of teaching, they should be actually seen first whenever you pick up your stethoscope. Because it is easier when your ear starts to hear louder sounds, it becomes very difficult, to appreciate these low-pitched sounds which are softer in nature. So, if you are suspecting, try to hear for these low-pitched sounds first, and then then focus your attention and your mind on the other things. There are many theories of S3 and S4 formations. Of course, the most common theory is vascular theory. S3 will happen in the first phase of diastole, when there is a gush of blood, and this blood will, strike. So anything in the ventricle wall, and anything that leads to an increase in the flow and hyperdynamic circulation will lead to an S3 formation. Left-sided, of course, is better heard. Left-sided S3s are better heard at apex. No effect of his respiration. Better heard in the left lateral position and associated with left-sided murmurs, while right ventricular S3s are in left parasternal regions. Increase on inspiration. They will increase when you have your passive leg raising, and they are associated with the rise of the DVT and the right-sided murmurs. The causes are many. We all know about it. It's physiological in children, young adults, pregnancy. There may be S3-like sounds, which are tumor flops and pericardial knocks. And then, of course, they may be pathological because of ventricular failure or because of any situation that leads to hyperdynamic circulation. And you all are well aware what are the situations that produce hyperdynamic circulation. The S4 is produced in the third phase of diastole, that is the atrial contraction phase of the diastole, and you need to have 3 prerequisites to have an S4. you should have a sinus rhythm. They will never be held in atrial fibrillation, a mistake many a times people make. They will not be heard if the AV valve is stenosed, and they need a non-compliant ventricle. So they are commonly seen, normally sometimes. One school of thought says that S4 is never physiological, but of course S4 is heard in older individuals, hypertension, aortic stenosis, and all the features that lead to non-compliant ventricular wall. Clicks are sounds that are produced either by valvular aperituses or by dilatation of great arteries. Rarely nowadays in clinical examination, but still of some theoretical value. Vascular clicks are generally louder, and when we talk about the vascular clicks of pulmonary artery, you may feel the pulmonary artery pulsations. Valvular clicks are generally softer, and when you talk about the aortic vascular click and pulmonary vascular click, the one thing that is asked sometimes in examination is that if your click is variable on respiration, what does it mean? What does it mean? So vascular clicks, clicks that are originating in the great arteries by the dilatation of the great arteries, are never variable with respiration. Your valvular clicks can be of different intensity during different phases of respiratory cycle, but that phenomena is limited only to the right side of the heart, meaning pulmonary valve click may be variable on inspiration, but aortic valve click will never be varied on respiration. And if anyone can tell me the explanation of that, it will be an icing on the cake. Yes, please. The hangout interval guy, huh?
Hello. Sir, in case of pulmonary ejection click, during inspiration, there's the inflow increases, and as such, the pulmonary valve is opened in the late diastole only. So when it comes to open in the systole, the valves, the leaflet have to cover a short distance as compared to the normal valve. That is why the ejection click becomes softer in inspiration.
But can it ever happen in the aortic side?
No, sir.
Why?
So basically, inspiration increases the right-sided inflow. Right-sided preload is increased with inspiration.
More importantly, in cases of RV failures, with inspiration, you get more blood volume, and transiently during the end of that inspiratory phase, you may have a situation where your RV end diastolic pressure is a tinge higher than your pulmonary artery diastolic pressure, and your valve slightly open. And because of that valve opening, the click becomes softer on inspiration. There is no way LV and diastolic pressure can be higher than aortic diastolic pressure. Okay? You guys get it? I mean, it's impossible to go into the murmurs in detail because each of the murmur will have different characteristics, each one will have different severity criteria. The time cannot allow that, certainly. But these are from my DM notes as I classified the murmurs, and of course not my classification, but as I tried to remember them. Two things I want to tell you. Always describe the murmur in relation to the heart sound. You end up saying it's an early systolic murmur, and then when someone asks what is the early systolic murmur, why you are saying it's an early systolic murmur, you are clueless. If someone says it's an early diastolic murmur, what does an early diastolic murmur mean? My guy in black shirt, yeah. Yes, you. What does early diastolic murmur mean? No, guy in front of you, yeah. exercise a bit. Early diastolic murmur, what is early diastolic murmur? Early diastolic murmur is heard in AR, right? What is an early diastolic murmur?
Start immediately after S2, sir.
So always describe. So 1/3 of the diastole is the length. What does early? Huh?
Start after the S2
Starts with the S2
and just at the one
and before S1.
peak crescendo.
Anything ends before S1. As I said, time your murmurs according to the S1 and S2. You can't describe the timing because it may be different in the severity of the aortic regurgitation. Any murmur that starts with S2 and ends before S1 is an early diastolic murmur. Similarly, what is an early systolic murmur? Yes, starts with S1. Ends before S2. Brilliant. So simple. Give me examples of early systolic murmurs. 5. I know, that's what I'm asking. It's very important because someone raised the question of the organic tricuspid leak versus the physiological tricuspid leak, an early one. There are no 5 causes, there are only 4 causes. When you are committing an early systolic murmur, you are only talking about these 4 things, nothing, no fifth. MR is a pansystolic murmur.
Yes.
Huh? Okay, so of course you have a very small muscular VSD that closes on in the later phase. It's an early systolic murmur. You have a very large VSD which has got produced pH now. The pH does not allow the pressure, a continuous flow in the entire phase of systole. You have an early systole and then it closes. The murmur shuts down. You have an acute mitral regurgitation. The LA cannot dilate so much to take blood throughout the diastolic. You have an early, and you have an organic tricuspid valve disease, which is again an early systolic murmur. It is non-pansystolic murmur. Pansystolic murmur means that the pulmonary artery pressures are elevated, and therefore it's a secondary PR. There are only 4 causes. So always describe your murmurs. What is the ejection systolic murmur? The guy in the check shirt, come. Yes, you. How do you describe an ejection systolic murmur? Describe it in relation to heart sounds. I don't know what isomer I'd have. What is it? What is it in relation to S2? S1 and S2 both you have to describe. Okay, it will start after S1 and it will end before S2. So that's why you have to. Continuous murmur is not the same thing as to and fro murmur. Continuous murmur is something that will engulf your S2 completely and not the 2 phases, not the seesaw murmur. It will engulf you. The continuous murmur can be described in such a way. So that's what I want to say, that always describe whenever anyone asks you, why do you say it's a, until and unless these are very simple things. This is not a rocket science, very simple things. Describe your murmurs in relation to your S2 and S1. And all of them will have one definite explanation or one definite definition. And follow that construct and you will know where it is. Should I carry dynamic auscultation? Sir? I'll take dynamic auscultation. I'll just take briefly, in terms of 2-3 minutes. I think my time is up. But these again are my DM notes from 2004. My first DM lecture, first DM case the presentation in seminar. 20 days after I joined my DM examination was dynamic auscultation. That's why I love this talk. It is a technique of altering circulatory dynamics by physiological and pharmacological maneuvers and see their effect on heart sounds and murmurs. Remember, do not do dynamic auscultation in clear-cut murmurs which are loud, clear and visible. Don't say that you have a very good mitral regurgitation murmur or aortic regurgitation murmur, and then say, oh, it is best heard in the, those are MBBS and MD things. If you have a clear, full-blown, severe murmur, well heard, no need to do it. It is only for faint murmurs and heart sound where you want to differentiate one situation from another, or you want to accentuate that heart sound and murmur. It is only for doubtful situations, not for main situations. Learn how to do the right way, because sometimes you want to impress the person. Okay, I did Valsalva and I saw this, and the examiner asks, how did you do Valsalva? You have no clue. So learn to do the right way, and of course in the days of echocardiography it is not needed, still it is needed to pass your examination, and at least the understanding of dynamic auscultation tells you much more about the circulatory physiology, so that you are well adapted to answer other questions. So if you have reached dynamic auscultation, it means you have know this circulatory physiology in greater detail, and therefore you will be better. So many dynamic auscultations, how to do it? Club them first. Valsalva is equal to sudden standing. They are same things. You get same findings. Muller's maneuver is equal to passive lead reading. You'll get the same findings. Club them together, correct? And then you can do squatting. No one does isometric exercises. You must know the technique, really useful. Amyl nitrate, never has any one of us done, but you must know, because it gives you a differential diagnosis of a couple of things. At least theoretically, you could have asked. You could be asked. So, theoretical exact way is to, for do Valsalva, is to push into a manometer and maintain a 40 millimeter pressure for 20 seconds. Maintain the 40 millimeter pressure for 20 seconds. Of course, it can be done in the other ways that you can go back and read. And remember that the changes, it is divided into 4 phases. Anyone knows the 4 phases of Valsalva? Okay, so the first, I said, sustain the pressure on the manometer for 20 seconds. The first 10 seconds is the phase 1. The next 10 seconds is the phase 2. As you end the 20 seconds, that's the phase 3. And a few seconds later is the phase 4. In phase 1, you have suddenly blowing it. There is increase in the intrathoracic pressure, so raised, so your aorta also gets pressurized, and you have a raise in the BP and the fall in the heart rate. But then, because of the sustenance of the pressure for the next 10 seconds, you get low venous return, and then both your right and the left side heart start to receive less blood, and your blood pressure goes down, your heart rate goes up. As you release, theoretically, you expected the BP to go high, but it doesn't happen, because the pulmonary capacitance suddenly increases and all the blood get accumulated in the pulmonary area. So again, you have a sustenance fall of BP and increase in the heart rate. And then there is a sympathetic overshoot in which your BP rises and your heart rate falls. So this is something that you get in the top panel. You have a raise in the BP, then you have a fall in the BP in the second phase, you have the further fall in the BP in the third phase, and then you have a systolic overshoot. It doesn't happen in something which is called as a square root response, where your BP tends to rise and it remains elevated in the phase 2 and phase 3, which happens in cases sometimes with ASDs, and we'll come to that. So how, of course, the correct way you have learned, the correct responses you have learned. I think we've gone too long, and it'll be loss of interest. So okay, so just remember that in Valsalva is equal to sudden standing, and Muller's, which is deep inspiration against the same close blotted, and the passive leg raising are the same, will produce the same thing. The only time they are generally used in the cases of HOCM and MVP. The murmur of HOCM will become louder while doing Valsalva, and MVP murmur will get longer while doing Valsalva. And these changes are seen in phase 2 of Valsalva, which is done. I would just come to the amyl nitrate. Amyl nitrates leads to, you can differentiate a couple of things. You can differentiate mitral stenosis from Austin Flint murmur. Austin Flint murmur, because of AR, will decrease on amyl nitrate, while as the mitral stenosis murmur will increase. TOF murmur, because of amyl nitrate, more blood will start going into aorta, more right to left shunt. So therefore, the murmur of the pulmonary area will decrease. The TOF murmur will decrease on giving amyl nitrate. HOCM murmur will increase and AR will decrease, but there will be no change in permeable vegetation. And of all the dynamic auscultation, it is only the right-sided changes, Muller's maneuver or passive lev raising or deep inspiration, that have got more significance, and other things are scientifically not much valuable in terms of, but still you must know. So I would end by saying that again, start with an empty slate in your mind, in your at least a long case. Keep history and possible differential diagnosis in mind while doing clinical examination. Before you reach the examination of the precordium, BP, pulse, and JVP are very important component. And once you have done your apical area examination, your diagnosis should be certain with you. See the whole picture. Don't rush after small findings in dynamic auscultation and forget the hard endpoints of how your apical impulse was, and listen to your examiners and be ready to attack whenever needed. I thank you for the opportunity, and I thank you for your attention.
Thank you so much, Rishi. It was a fantastic demonstration, and then covering the whole thing. I think probably it's worth for all of you making all the way to this place, and then listening to Rishi and Dr. Sethi and all our faculty members. Before we take a tea break, quickly some 2 to 3 questions we can entertain. Anything? So everybody is clear. Okay. Yeah, go ahead.
Hello.
I believe what you are trying to ask me is that sometime when you feel in mitral stenosis, you can feel your S when you say that it's a tapping apex beat. So that's essentially when you can feel your, but then when you talk about the apical impulse in general, tapping is a normal apical impulse, and it is a combination of a normal force, and it is not sustained. So it is tapping because it is just tapping you and going away. But tapping is sometimes also used in cases of mitral stenosis when you get a tap with S1, and then that's a different connotation for saying. It's better not to say tapping when you are talking about mitral stenosis situation.
Anybody else?
Good evening, sir. Clinically, how to comment on the narrow splitting of second heart sound?
So narrow splitting. Normal splitting would be a narrow split sound. You can only say that it's a normally split sound when you can hear the splitting in inspiration and you cannot hear the splitting in expiration. When that normal becomes a narrow, I would not say that is something that we should go into how many milliseconds, because there it's a phonographic findings. And I think when the narrow becomes so narrow that it becomes single, or it becomes more narrow and it becomes a reverse splitting, that is the time we should comment upon it. Otherwise, you can just simply say that I can hear the normal splitting, in which I can hear the splitting during inspiration and I cannot hear anything during expiration. It's a normal splitting sound. There's no, I would not advise you to say that the S2 is narrowly split and trying to say that the LV obstruction is producing that, because then it would be you're getting yourself into some trouble. Yeah. Only speak when it has become so narrow that it has become single or reverse. Otherwise, you can only hear in inspiration you can hear splitting, in expiration you cannot hear splitting. That's the only thing human hear can do. Otherwise, rest are phonographic findings.
As a patient of severe aortic stenosis, how would we say that
In severe aortic stenosis, A2 is tend to be soft. A2 will tend to be soft because, so how do you say? Why do you need to say this? If you are not hearing the A2, because of a severe calcification, if you're hearing only a single sound, then it's wiser to say that, I'm hearing a single sound. Everything else is constructing it to be severe aortic stenosis, and I would contribute that sound. I'm not hearing any splitting, and I would contribute that I'm able to appreciate P2, but I'm not able to appreciate it. That's what happened in just the last case that my resident was presenting. But then he said that I can listen to the second heart sound at the apex, implying that the P2 is now heard at apex. You get what I'm saying? If you are only hearing one sound and you are not getting a splitting and it's a severe aortic stenosis, you can say that it's the pulmonary sound I am hearing. I think I cannot appreciate the aortic sound because of the severe aortic stenosis. But then you cannot say that second sound is heard at the apex also, because then it means a severe PAH. Then you have to justify the severe PAH at your clinical examination, which would be very rare in isolated aortic stenosis.
Okay, so with this, we'll take a very short tea break. Please come back within 10 minutes because 2 important lectures are there and they'll be really useful. So please come back within 10 minutes.